few more folks joining, but thank you everyone for joining our pepper rounds today for October. We are really excited to have Dr. Sandra Shi here speaking with us. She is a geriatrician and instructor of medicine at Harvard Medical School and the Hinda and Arthur Marcus Institute for Aging Research at Hebrew SeniorLife. Her research centers on frailty and post-acute care in skilled nursing facilities, leveraging large databases, including national surveys and Medicare claims data to study post-acute care outcomes and rehabilitation. In 2024, she was honored with the Health and Aging Foundation New Investigator Award from the American Geriatrics Society. She's been an NIA Butler-Williams Scholar and she has an R3 GEMSSTAR awardee. Dr. Shi's ultimate goal is to integrate geriatrics and rehabilitation sciences to develop interventions that improve the overall quality of life for frail older adults. Her multidimensional approach to aging research emphasizes personalized patient-centered outcome to empower older adults and their families in post-acute rehabilitation journey. And Dr. Linder shared with us that Dr. Shi was named a Stat News 2025 Wonderkin. I think Dr. Linder will put that in the chat for us later, but that's really cool. All right, Dr. Shi, I'll let you take it away.
Thank you so much for the very kind introduction. While I was preparing this, I was getting really excited because, to be honest, this kind of feels like I'm coming home a little bit. Does anyone recognize this place? I doubt it, but I shot in the dark. This is, I had to Google, it's now apparently called the Pearl or Symphony of Evanston. But I know this place as Mather Pavilion. This is where my journey in geriatrics started. I volunteered there for 3 years when I was a Northwestern undergraduate. And it's actually where I wrote my medical school personal statement on a resident that I met there. And this is where I first learned the word geriatrics, and I learned what it meant to take care of older adults. And ironically, the seeds kind of planted there from that experience of being a rehab volunteer have just kind of continued to teach me and continue to blossom and just kind of give me energy in life and what I'm doing. But I'm so honored to be here now. And if again, it kind of feels like I'm coming full circle with my Northwestern moment. And I was really it was wonderful to kind of think back to this time and some of the things that I've learned and those lessons carried forward. So in terms of conflicts of interest, I don't have any relevant financial relationships to disclose. I do have research funding through an R03 GEMSSTAR award. Some of the data, which I'll be presenting here, I was generously funded through OAIC REC award on peppers under a pilot, which I'll also be presenting here. And I was, as of last month, just awarded a BSIN award as well, continuing work in integrating intrinsic capacity and frailty in post-acute skilled nursing facilities. So I really tried to structure my talk today in really 3 parts. And the first one is sort of post-acute care as I first learned about it as a fellow and what the state how the world looks now, and it's pretty much how it's looked for the last 30 years of post-acute stiff care. And then going into part 2, I'm going to try to introduce some tools that hopefully can change that lens that we're reviewing this world with. And my hope is that by kind of combining these together, we'll be able to bridge to part 3, the road ahead of how we can improve rehab care for seniors. So with part 1, I'll start here, and this is Hebrew Rehab. This is where I work now on the rehab floor as a geriatrician. The rehab floor is the second floor here, it looks, ironically, I was realizing it looks like a little bit similar to the Mather in some ways, sort of this concrete building with streaky windows. But this is where I, as a geriatrics fellow, was first introduced to the idea of post-acute rehab, post-acute SNF care, and really saw what it meant for older adults to rehab after hospitalization. And it's here where I met a patient that really changed the way that I thought about how rehab could look for older adults. So I will be starting with John, and John will be, he's a bit of an amalgamation of various patients, but he actually is very much based on a true, real patient. He was an 83-year-old veteran. He presented to the emergency department after a fall. He was ambulating to the bathroom. He has a medical history of hypertension, CAD, diabetes. He has chronic AFib, arthritis. He has essential tremor and vision impairment. His syncope workup was negative in the ED. He didn't have any major injuries, so he kind of met his 3 midnight requirement in the hospital and then was sent to rehab at our SNF after PT kind of recommended rehab. And so he, when I see him, asked me the question that almost every patient was asking me, which was, when can I go home? And as a geriatrics fellow, that was I did this rotation very early on in my fellowship. I was basically an internal medicine resident at that point, and I realized that I had no idea how to even start answering that question. I didn't know when he would be able to go home. I didn't even know if he could go home. So I did, you know, did what I knew how to do, which was I opened UpToDate and PubMed and I guess now Open Evidence or whatever, smart search engine exists. And I said, well, all right, what does it look like for these old adults when they're starting this journey? I had been aware of the journey of community dwelling older adult goes to the hospital and then they go to the nursing home. And I knew that they were going to get nursing care, physical therapy, maybe occupational therapy, and some speech therapy for some amount of time. Um, and understanding that first half of the equation was really only understanding part of the picture. And so it wasn't until I started digging into the data that I realized that only about half of these patients were going home to the community. A fifth of them were getting rehospitalized, a fifth of them were transitioning to long-term care. And so they were actually never kind of quote unquote going home, going back to the community setting. And actually a good chunk of them, 5 to 10%, were even actually just dying. And so I realized that even though SNFs are a really critical recovery setting for 1 in 5 older adults that is going to the hospital, outcomes were really poor. And it's interesting when I first started looking at this, I was really shocked because I think being a fairly optimistic person, I had assumed that my patients, of course, they were, I did such a great job taking care of them in the hospital. I deprescribed all these medications. I'm sending them to rehab. They'll get stronger and go home. And yet, when I realized that for half of my patients, I was potentially misleading them when I was giving them the sales pitch to on their discharge journey. To me, that was a bit of a gut punch. And so when I started my postdoctoral fellowship, and I was really interested in what does this journey look like for patients. And so part one was just, how do we even predict who's going to improve, who's getting these poor outcomes or experiencing these poor outcomes? What does this journey look like for them? So I prospectively followed a small cohort of older adults admitted to our SNF. I will caveat that it turns out January of 2020 was a terrible time to enroll a post-acute SNF cohort. And so I pretty quickly, unfortunately, had to stop enrolling because COVID hit our unit. But I was able to enroll, about 30 some older adults. And what I essentially found, first of all, was when I measured frailty in these older adults, uh, then it was about like pretty even split. 29% of them were sort of pre-frail or not frail, but otherwise 21% of them had severe frailty, 25% had moderate frailty, and 25% had mild frailty. So it was really a pretty even split across when I started prospectively kind of measuring frailty rigorously. And then this is one of those diagrams that kind of changed the course of my career and how I think about recovery for older adults. What I realized is that for patients who are not frail or mildly frail, that blue and purple line, then if we look at the nadir here, the nadir here, which is the time of SNF admission, then what you see is almost everyone comes to the skilled nursing facility and they're understandably sort of at the lowest point of their functional status. They've had this hospitalization. They're dependent in activities of daily living, and they're here to rehab. And for the people that are not frail or only have very mild frailty, they bounce back pretty quickly. And the black arrows here are the SNF discharge. So this is the discharge from the skilled nursing facility. And you can see that they're almost back to their baseline. It is a little bit interesting here that the people who aren't frail are discharged and then they kind of continue to get better over time versus the people with mild frailty who, are actually sometimes doing even better than they were before they went to the hospital. And then sometimes they kind of slip back down a little bit. And I continue to call these patients after they discharge home. I called them a week after discharge, a month after discharge, and then 90 days after discharge. And I was just asking questions like, activities of daily living, interventional activities of daily living. But I was also curious about like, did they have any falls at home? Did they maybe have to hire extra help to stay, or did they actually move to a different place? And what I found was that it was pretty common for people to have kind of these serious life changes or have to make serious changes to how they're living their daily lives to either stay in the community or for some of them actually moving into more supportive settings. But one of the hardest parts of this project was that for those with moderate or severe frailty, that yellow and red line, then not only did you can kind of see by where these black arrows are, it took them much longer. They were in the SNF longer because it took them a lot longer to just rehab. They never really got back to their baseline. And the lines are a little bit misleading here because actually I could no longer reach about half of those patients or more. Some of them had died, some of them were lost to follow up. And for a lot of those patients, I would call and it turned out they were rehospitalized and I could never get a hold of them again. And so for those patients with moderate or severe frailty that I was in some ways the most interested in what their lives look like, what was their quality of life, I wasn't able to actually reach them even from this kind of prospective telephone follow-up work. So I switched to Medicare claims data because at least then I would be able to see if they were rehospitalized or if they were dead or alive. In this study that looked at almost 100,000 post-acute discharges, what I'm measuring here is something called time at home. And this is literally just, are you alive and are you at home? So if you are in the hospital, if you're in a SNF, if you're in the emergency department, then that does not count as time at home. And we're just literally measuring in the 6 months after somebody was discharged from a skilled nursing facility from a post-acute SNF, how much time were they actually getting to spend at home? And when we stratify out by the frailty measure here is now a claims-based frailty measure. But what we similarly see is for that moderate and severe frailty cohort, this kind of explains why it was so hard for me to reach them. Because if you look at, the 1 in 4 patients, they're not even at home for the 2 months out of the next 6 months of their life, if they're even alive. And when I compare it to admission diagnoses and things that oftentimes from like billing perspectives or hospital systems perspectives they would think about, that's comparable to patients with cancer. And yet this was definitely not a lens that I was necessarily thinking of these patients with. I think when I often would admit patients with cancer, immediately we're thinking palliative care consults, we're thinking about, plugging them in, maybe even considering hospice referrals. And yet for those patients, that half of patients with moderate to severe frailty, it wasn't necessarily triggering the same sort of reaction. And I'll show just one more slide, which is what about the lucky bunch that makes it home? I mentioned about half of people do get back to the community. So when we actually look again with Medicare claims data, this time it's collected through the administrative assessments done for people who go home to the community and get home health care. Their home health care agencies collect information that's reported to Medicare about how they're doing functionally. And so what we can basically compare is, all right, before they went to the hospital, this is, the number of ADLs that they were independent on. And after, over time, as the home health services are going in and they're doing the regular assessments, how much of them are recovering or going back to their baseline. And what we see is even if patients are lucky enough, we can see in the non-fail cohort, those patients, when they go home, they oftentimes are not maybe fully functioning recovered, but over time, the green bar here indicates that they're pretty much recovering. And most of them are, the vast majority, almost 80% are really regaining their prior level of function while they're in the community. Conversely, those with moderate frailty, once we kind of follow them out 60 days, 75 days, 90 days, half of them really have a new disability and inactivity of daily living. And from my palliative care colleagues, when I presented some of this work to them, another thing that they sort of highlighted is that they sometimes talk about time limited trials, and a lot of families and patients just want to know, like, let's just go home and I just want to try and see how much better she'll get and how long do you try for. And the interesting thing that they picked up from this is that it almost looks like after 2 months, if somebody is not able and hasn't kind of successfully regained the ability to say bathe or shower, they're unlikely to really be making further progress from like a therapy perspective. So even if they make it home, it's unfortunately not always a happy ending. And this was illustrative for me in terms of thinking about how I counsel families and their expectations of if they go home, how much support are they going to need to really have that be a sustained, durable return to the community? So this is really wrapping up part one of what I wanted to discuss, which is that measuring frailty, hopefully, the way I see it is it really helps us find those patients that the healthcare system is going to fail. And I intentionally say the healthcare system is going to fail, not that the frail patient is failing, because frailty is very much part of aging, and there's nothing wrong with aging. There's nothing wrong with over time needing more help with some of your activities of daily living. What we want is the healthcare system to be able to meet people where they're at, provide them the support to maintain independence and maintain, their ability to participate in activities that matter to them. And so frailty is, the way I see it now, is a way to help us find those patients that the healthcare system needs to kind of step up and be a little bit more flexible or a little bit more proactive in helping. So at this point, I recognize that frailty was a major predictor of recovery, even for those that go home. Many were not returning to their prior baseline. And so next part, I'm going to talk a little bit about the frailty difference. And up until this point, when I told you about John, when I first introduced the story of John, our veteran, who was coming to rehab, maybe this is what you were thinking of, which is the mocha that I did. I asked him to do a clock draw, and instead of writing, I gave him the time 10 past 11. He just kind of drew the smiley face. So maybe this is what you picture. You probably don't remember his list of medical conditions because they were sort of bland, vanilla, hypertension, diabetes, things. Um, but here's how I hope that you'll remember him. He had a very wide tooth smile. He had glasses. He had a very close friend, Edna, who was his neighbor and companion. And they liked to do word puzzles together. And actually, we learned from her that he really liked to color and paint. And so this is actually a drawing he painted when he was with us at rehab. And you can already see some of his creativity. I would never have picked green for an elephant. And honestly, as a mother, I have a 9-month-old and a 2.5-year-old. He is staying in the lines way better than either of, my girls, certainly better than my toddler. But clearly his vision impairment was also not stopping him from doing what he really enjoyed in his spare time. So in the next part, I wanted to really start thinking about the difference that the frailty lens can make. So I mentioned that there's all these comorbidities and there's the presenting reason he went to the hospital. So how do we take this and how do we measure frailty? How can we actually transform this into a rigorous assessment that's portable, that's durable and meaningful? And so our group is really, this amazing team that I work with has tried to make it as easy and practical as possible to reframe thinking from these diagnoses to overall vulnerability and reserve in a really quantifiable, objective way. So I have here the QR code. There's also the link at the bottom for efrailty.org. But now what I actually do in clinical practice every Monday when I go to do admissions with my rehab patients is I do my usual assessment, go through and ask them about their medical history, their chart review, and then I go to efrailty.org. The one that I most commonly use is this one, which is the Comprehensive Geriatric Assessment-Based Frailty Index, or CGAFI. It's also actually the most popular one on the website that we actually happen to have up in terms of just clicks. And it seems like when people are on it, one of the things that kind of Google helps us track is how long people are staying on the page. And it does seem like people are staying on the page long enough that they're actually using it, not just kind of closing it, opening it, looking at it, and closing it. It's the most comprehensive, but it's also the most informative. And I'll show you a little bit more um, uh, in a second. So essentially what I would do is after I see a patient, I would go through and just click what are the items or the parts of their medical history that are relevant. And this is a pretty simple, just kind of click through form of some medical conditions, activities of daily living and instrumental activities of daily living, as well as some physical tasks. And what we really like about these is it helps to capture, sometimes people are, our patients can be a little wishy-washy, or, oh, well, I'm never the one that used to, do grocery shopping. I could if I wanted to. But if you pin them down and say, well, could you lift or carry a gallon of milk, which is about 10 pounds, then that's a little bit easier for them to say, yes, I can do that, or no, I wouldn't be able to do that. And performance tests, which honestly in the post-acute setting are a little bit trickier for me because I recognize that I'm sort of capturing patients at their worst. So oftentimes I don't necessarily put this in unless, of course, cognitive function is the one that I do try to put in as much as possible. And here you can either just click the score or you can actually input the points if you actually put through the entire thing. And there are 4 different cognitive function tests that we have here that you can input. And if you go through all of this, what we generate at the end is the frailty index, which is now calculated. And if we plug in John's data, actually, what I found is that he had moderate frailty or a frailty index score of 0.365. And what we try to graphically illustrate here is not just the fact that he has moderate frailty, but what are the domains that are really driving that frailty? So in particular, he has very high mobility impairment and he has very mostly a disability or dependency in his instrumental activities of daily living. We also plot relative to a cohort of US older adults where he is. So the solid line at the bottom is the average score for women and men in the US. And then the 99th is sort of highest percentile to give people a sense of like kind of how bad I can get. And then the last thing is I'll mention in terms of just the vulnerability by domain, what we find is that this can be really powerful in terms of communicating with patients and care teams more broadly about not just why we're worried, like you have moderate frailty, but specifically what we're worried about. You have moderate frailty because you have a lot of mobility limitations. And one last thing I'll highlight really quickly, which is a newer feature. If you click this, you have the options of either saving the results as an image or even copying results as a task. If you hit image, then it actually just copies this exact image. And for folks that are on Epic, you can actually just copy and paste that directly into your note. For folks that are using other EHRs like Point Click Care or Meditech or at the VA, CPRS, then this actually can auto-generate text for notes. So I was literally sitting there clicking and thinking, why am I like duplicating my work? Why can't this thing just basically write my note for me? And so we programmed it to basically do this. If you click save these results as a text, this is literally just copy pasted directly from what was then copied, which is that this patient has moderate frailty, this is his FI, these are the deficits that were assessed. It also summarizes the information I plugged into it regarding ADLs and IEDLs. So trying to streamline this process a little bit and again, improve that portability. And up until this point, I've mostly been focusing on the deficits, but we even have things like, if you were to scroll down and look at the assessment and plan section, suggested things to address that high vulnerability in mobility or high vulnerability in disability. This is going to be personalized to the profile that was inputted into the website and prioritized. So if for whatever reason a patient had very high vulnerability from the perspective of nutrition, nutrition would actually pop up to the top here. If somebody didn't even do a cognitive assessment, then it would say basically not insufficient data to calculate that, and some general suggestions would sort of be popped up. And then last thing is that we do have that 1-year risk of adverse outcomes based on frailty index to give people, again, a sense if we're communicating or trying to prognosticate, this is what your risk is of having a new ADL disability, of having another hospitalization, and trying to help give patients and providers a little bit more information to help with that communication. So hopefully now I can take that lens of just a bunch of medical conditions and a little bit of functional data and say, well, comprehensively, we've calculated that John is an 83-year-old veteran and he has moderate frailty. This means if he goes home, he has a 50% chance of having a new disability based on that kind of green bar functional graph that we looked at. And he also has 3 times higher odds of having loss of time at home, meaning a clinically significant loss of time at home. And so instead of just focusing on his comorbidities, now I want to think about John in terms of his frailty and his resilience. The big question being, how does this actually change what we do in the post-acute setting? We have all this information. Maybe it's made copying and writing my notes a little bit easier and hopefully standardizing some of this language so that we can talk to our care teams and colleagues and patients and families about this information. But what I'm really interested in now is developing innovative strategies to leverage resilience and personalized rehab. And I mentioned that I want you to think about this green elephant painting when you think of John. And the reason why this was such a game-changing moment for me is because John had painted this picture during his physical therapy session while he was standing. And so John actually wasn't doing very well with physical therapy at first. He was really sort of demoralized. He, I mentioned, was living alone. He had this friend, but he was really worried at this point. Was this fall going to be the thing that made him have to, you know, move into an assisted living or move into another setting and away from his friend, and away from the community and his home of 30 years? And that is a really frightening thought for many older adults. And I think some can be kind of motivated by it, but for others, that can be very intimidating. And what we found was that actually John really loved painting, and by embracing his hobbies like reading and painting, those are strengths that we use to kind of promote resilience. And the beautiful thing about having him do this while standing up is that at this point, he's not just doing the practice of standing up, but he's integrating so many core functions. He is now having to work on dynamic balance and dual task loading. The fact that he's not just standing and thinking about standing or walking, but he's actually thinking about painting. He's using his functional reach to reach over to the paints, and coordinating, between his hands and his eyes, and working on, overcoming the essential tremor. And so for many, uh, and I will mention that this is not the only painting that John painted while he was with us. He was a very prolific artist when he was with us. So he this is several years ago, so engravers was very popular at the time. Our recreational therapist was delighted because he literally used up all of the art paint kit, like literally every art kit that we had. She had to buy more art supplies. He was an extremely prolific artist while he was with us. Not all of these were painted in the context of his physical therapy sessions. Some of them were just sort of hobbies, but he actually painted so much that at his discharge, we had like a goodbye gallery, little kind of mini art gallery session for him, where we got to show off his work a little bit. And yes, he was able to successfully discharge home despite his moderate frailty. And so for many years, this is where my presentation would end. I would say, I had this really cool case of this patient, and we were able to do this really cool thing and kind of turn around to a success story. And I'm really excited to say now this is actually becoming a bit of a new start for me. So hopefully I've convinced you by now that frail patients have diminished resilience, and it's really critical that we find these patients because we want to know that, if we find these patients early, then we can ideally personalize connections to support them, and leverage that in a way that the healthcare system, unfortunately, the way it is right now, they would potentially slip through the cracks. So in terms of the road ahead, what I'm really interested in is how do we use frailty to identify and individualize care for these high-risk patients and improve their functional recovery. Uh, So the next part of the talk is going to be the Pepper Center funded pilot that I did in skilled nursing facilities. Um, I will say right now, I'm not at the level where I can fully personalize at the individual level and have every single person paint green elephants. But I thought, well, at the very least, what we should be doing is addressing their frailty and giving just a little bit more than what standard care is doing. So I wanted to try a multi-component frailty intervention because we have good literature supporting that protein supplementation and resistance exercise is beneficial for patients with frailty. And yet this is not explicitly addressed in post-acute rehab. Patients might get a supplement, but that's oftentimes Ensure, which is, or Boost. And so that's often, high calorie. The focus is not really protein, it's actually more just fat and calories and sugar. And oftentimes they don't taste all that great. Sometimes they're used to actually, they come on the meal tray, and so the patient will drink. I would see my patients kind of drink the Ensure, and then they're too full and they don't actually eat their food, which is also very counterproductive. And then the other thing is that we know supplementation is actually most beneficial when it's consumed within 30 minutes of exercise, for synergistic benefit and addressing sarcopenia and muscle loss. So wouldn't it be great if we could just have patients do just a little bit more exercise while they're in rehab? It's really hard to time supplementation within a PT or a physical therapy rehab session, because those can be very chaotic, and sometimes people come in the morning, sometimes in the afternoon, sometimes patients are going out to appointments. And so what we decide to say is, well, we know more exercise is better. Is it possible to maybe have patients do just a little bit more exercises and encourage them to do those extra exercises while they're in rehab? So the part one I mentioned is the protein supplement, which was a minimum of 15 grams of protein, anywhere from 15 to 20 grams. This was individualized to a participant's taste and preferences. And so basically this was in the form of whatever they're willing to take, I will provide it, whether that was a protein bar, a protein shake. We had this like gelatins, a protein gelatin that was like kind of fruit flavored, light, low calorie was the goal. We didn't want it to be filling. We wanted it to sort of be a snack that boosts protein and again is not replacing meals or real nutrition. And we also had some vegan patients, so we switched to vegan protein instead of whey protein. I joke my office looked kind of like a bodybuilding shop at one point because I had so many different supplements that I was just trying to find something that would work that I could again individualize and tailor to a participant's preferences. And then these exercises were sort of co-developed with our physical therapy department. I sat down and asked them, what if you could select 6 or 7 exercises that you think, broadly speaking, we could probably capture the entire spectrum of patients who just came from the hospital and are really deconditioned, all the way to they're doing totally great and they're almost, they're ready to go home. What would that span of 6 or 7 exercises be? And then once somebody enrolled in the study, we would ask their physical therapist, just choose 2 or 3 exercises that you think they can work on this week. Tell us how many reps you want them to do, how many sets you want them to do. And we would have the CNAs, the certified nurse aides, or volunteers go and essentially supervise or encourage that patient to do those exercises with them. I really wanted this to be representative as much as possible of the patients that were coming. So I tried to have very broad inclusion criteria as much as possible. As long as they had to be community dwelling before hospitalization, they had to be older than 65 years of age, they had to be coming from a hospitalization, although this was tweaked a little bit later on, they could be coming from the ED as well. They had to speak English for the purposes of consenting and participating, and they had to have at least mild frailty or worse by clinical frailty scale. We enrolled, this program was at 2 skilled nursing facilities in the greater Boston area, and we enrolled for over the period of about a year. So we actually ended up screening every single admission that came in. So there were 515 admissions that we screened. Going through the exclusion criteria now, by far the most common reason why folks were excluded was either their primary clinician didn't think they were appropriate for the study, or this included healthcare proxy activation, meaning that they had cognitive impairment or delirium to the degree that they were no longer able to participate actively in their clinical care nor research. And that actually excluded the vast majority of participants. We had to exclude people who had stage 4 kidney disease or worse because of the protein supplementation part of that. We have a fairly large non-English speaking community of patients, and so they were also excluded. I have an asterisk here. ED discharges, the initial protocol actually required people had to have had that full like 3 midnight experience in the hospital, and then we actually ended up waiving that later on in the protocol. So folks that were coming straight from the ED were eligible as well. There were some folks that were coming to the skilled nursing facility, and the plan was for them to just transition into long-term care. They were not planning to go home anymore. And so we also excluded those participants. And then, of course, anybody that was NPO or had a feeding tube was also not eligible because they wouldn't be able to take that protein supplement, which left us with 147 eligible patients. Of those, about 11 of them, we weren't able to get to them within 72 hours of them entering the SNF, and about 86 of them actually declined. I don't have the data officially here, but I can say of the folks that refused, they kind of fell into 2 buckets. One was the bucket of folks that were really overwhelmed and felt like that the regular therapy that they would be getting would be enough. And that they were too fatigued or tired to really be able to tolerate anything extra. And then the other bucket of folks were folks that were like, I'm only going to be here for a week. I'm gonna, rehab super, super quickly and super fast. So I don't really see a benefit of enrolling in this study to get extra exercise since I'm only going to be here for a week. So that was kind of interesting that those were kind of the 2 flavors of general refusal. We enrolled 50 participants. Of those, 11 withdrew from the study. And 4 were hospitalized. 1 actually left AMA. This is how you know I wasn't making up this data. The participant just left the SNF ANA, and so we were not able to collect any follow-up on that particular person. Of those that withdrew, interestingly, most of them were actually pre-frail, and they did about 73% of that cognitive impairment. 40% of them transitioned to long-term care. So the folks that were enrolling and then withdrawing were tended to be they tended to be participants that were also not engaging in regular physical therapy as well, and sort of unfortunately not really engaged in even the regular PT. The cohort that we did enroll, this is of the entire 50 patients that we enrolled, they reflected the mean age of our actual unit of the units, which is about 80, 81, 82 years old is the average age. 68% of them were women, largely white predominant, and mean frailty was sitting in that moderate frailty mild frailty category. Interestingly, when we looked at frailty status, only about 4% of them had severe frailty, and 34% of them had moderate frailty, 40% of them had mild frailty, and actually 22% of them qualified only as pre-frail. They didn't technically meet frailty by the kind of rigorous frailty index criteria. But among those that did complete the intervention and stuck through with the whole thing, the vast majority were really satisfied with it. They generally really liked the exercises. They were really happy with their progress throughout the study. They really enjoyed it. Some of them had some feedback for us that they would have preferred for the exercises to be at the same time every day, right after occupational therapy, which is interesting because we also had some folks give us feedback that they actually wanted them to be separated because they were too tired after their therapy session. So speaking a little bit to trying to personalize, individualize this as much as possible. We had a participant who was lovely. He wanted us he for some reason thought that this program continued in perpetuity. And so he actually wanted us to continue go seeing him in his home after he was discharging, which was not going to be possible, but we appreciated the feedback. And the one kind of we had some neutral comments. The interesting thing is one of the neutral comments was actually that the participants said they wish they could have done more. They really love what the study was doing. They were just feeling too weak. So in some ways, speaking to that, again, the fatigue, that lower endurance that we see with frail patients and their ability to tolerate extended therapy session and extended rehab and exercises. In the preliminary physical function data, what we were saying is that of those that completed the intervention where we measured their admission, functional status and measures, and then discharge functional status and measures across measures of things like grip strength, their Barthel index, and then also the AMPAC score, which is a post-acute kind of functional score for mobility, we were seeing improvements across the board. I will say I don't think that this is, because of how great this intervention was necessarily, because these patients were also going through their regular wonderful care with their physical therapy teams and their occupational therapy teams and medical care and recovering over the course of their stay at SNF. But compared to some of the historical data that I had from my prior study, which was just kind of observational perspective, it does seem like they, particularly in grip strength, seem to be improving more than one would expect from just regular kind of standard of care therapy. And then the interesting thing I did mention, and of course the question always comes, there were those 11 folks that withdrew from the study. And I can tell you that very interestingly, about 8 of those happened in the first half of the study. And this speaks to, for me at least, lessons that I learned in terms of feasibility and designing interventions for frail, complex populations. Most of the participants we had would say that in the first week of admission, they were just too tired. So we would go in after their physical therapy or occupational therapy sessions, and we would say, time to do more exercises and eat this protein bar. And they were just really exhausted. And so after that happened, we were going in, 5, 6 times a week. Every day we were going in, sometimes 2 or 3 times a day, and we were going in 5 or 6 times. That oftentimes they would sort of get demoralized and at that point withdraw from the study and say, I don't really think I'm benefiting from this. I'm just too tired to be able to do anything with it. And so we ended up introducing patient priorities care as part of the intervention in the latter half of the study. And this actually reduced our study withdrawal rates from about 39% to 8%. And all we were doing was going in with a self-guided module on the worksheets and saying, what matters most to you? What are the barriers that you're experiencing right now to your recovery and your goals? And what are things that are really helpful? the responses really varied, but in terms of that single powerful question of what matters most to you right now, um, I generated a word cloud from the responses in the worksheet that participants filled out with us. And you see here that by an overwhelming majority, most of them were saying, what I really am focusing on right now is my independence and being able to go home. Oftentimes it was specifically maybe walking or balance or strength was a big one, having leg strength, but also like mental strength, which was interesting, having connections and being able to spend time with friends and family. Um, and so oftentimes I think in in interventions, again, this was a frailty focused intervention, and I was targeting patients with frailty, but really caring for frail older adults is in many ways just caring for all older adults because the priorities are the same in terms of building strength and being independent and going home to spend time with friends and family. So when I think about frailty in the post-acute care setting now, I still feel that measuring frailty again helps us find those patients that are most vulnerable, that the healthcare system is going to fail. And frail patients have diminished intrinsic capacity themselves, they have diminished resilience. And that frailty assessment allows us to be rigorous in a way that narrows down what are the domains that this person needs to focus on, and how can we personalize the connections that need to support them. So, in terms of the road ahead for me, my goal is really that frailty assessment and personalized recovery can become standard in every SNF. This is what I am hoping to do in my future work and what I'm hoping to build towards in, I mentioned my K award, that I would really love to find a way to kind of standardize this journey for patients in post-acute care so that we're improving outcomes for all older adults. That is all I have. I have more slides I'm happy to go into and take questions at this point.
That's great. I mean, we'll have to imagine the thunderous applause of everybody who is on mute. But yeah, Sarah, do you want to?
Yeah, that was so great, Dr. Shi. It's so important. We see this way too much. I'm looking, is there any questions? Please put them in the chat if you have a question. You're not able to unmute participants, but if you have any questions, please do put them in the chat.
And I can lead off with one. I am curious about, and this is going back a ways in your talk though. I'm curious about your experience using the Medicare data, just sort of as a researcher, what that was like, and then particularly, can you just say a little bit more about the claims-based frailty index?
Absolutely. So thank you for that. And I definitely, it went kind of pretty quickly over it, but I'm happy to go back to that side if it's helpful. So using the Medicare claims for me was one of the big learning points of my of my fellowship because it is very different. I'm used to being able to kind of go and measure things exactly the way I want it and, follow patients and call them and get those answers. And I think the big power of using Medicare claims is sheer numbers and accurate capture. Like I know that somebody was hospitalized. I know whether somebody's dead or alive. The big thing that's of course going to be missing is the quality of life data. And honestly, the big thing that I miss as a geriatrician researcher is functional status is often just not captured super well.
Yeah.
It is captured, fortunately, for post-acute care patients because we have the minimum data set, which is captured for all nursing home patients and the on admission and then sort of on a quarterly basis. But because it's real world data, it can be very messy. And so cleaning that data and parsing it out and trying to create a timeline of patients alone was like a 1 year kind of slog through like hundreds of thousands of these kind of Medicare records. I will also say that the data, I was very fortunate that my mentor Daycam had the data sets already in house, and that allowed me as a junior researcher to be able to access them and use them. Because Medicare data is now moving onto the cloud in enclaves, it is unfortunately become a much harder to access. You have to pay per seat and pay for analysts. And at that point, I do think that for some junior researchers, it's becoming almost cost prohibitive. They just won't have the ability to work with that kind of level of data set that early on without having kind of funding for it. But there are smaller data sets that are like the Medicare Current Beneficiary Survey, which is a smaller data set, but it's a survey, and that's actually much more affordable and much easier to use. So I think still opportunities for junior research to use that. The claims-based frailty index that I used is developed by my mentor, Kim. That specifically, it is trying to measure a frailty index, but it's not just ICD codes, which is what a lot of frailty indices do, is they just kind of look at comorbidities. And at that point, it's basically just a comorbidity index. But specifically what it's pulling from is also HCPCS code, so durable medical equipment. So if somebody has a walker or somebody has, grab bars or those sort of things ordered, and prescriptions for wheelchairs or oxygen, then all of that is information that can be leveraged then to try to estimate, all right, if somebody's getting a walker prescribed for them, they probably have additional frailty. So it's very powerful, especially as a tool to try to approximate frailty in these data sets where we typically wouldn't be able to measure it. But also it's particularly good at predicting healthcare utilization. And you can imagine, because it's using, cost data and it's using healthcare utilization data, then it's really great at capturing it. We find, especially for these kind of mild, moderate frailty patients that are engaging with the healthcare system, it can measure frailty really very, very specifically, and with a great deal of accuracy.
Yeah, that's great. So I'm a general internist and often I'm critical of my geriatrician friends, love my geriatrician friends, but and this is not unique to geriatrics, but just too precious about functional measures or even grip strength, which is like we're never going to get that in primary care, right? And so looking to questionnaires, claims data, what can we use that's scalable that we can just do on hundreds of thousands of patients and identify those at risk. So that's very interesting. And do you see a role for using it practically? So you've used it for a research application, but what about, clinical application about like, hey, we're getting feedback that you do worry about sort of careful quantitation of the obvious. It's like, I know this person's frail. I'm the one that ordered the walker.
Yes.
Right. But yeah, is that a possibility, you think?
So absolutely. Kate Callahan at Wake Forest has done
Yeah.
awesome work in, integrating frailty indices into the EHR.
Yes.
And I think that a lot of that's increasing the direction we're seeing this work go, is integrating into EHRs. Again, trying to harvest that data. A lot of that is going to be comorbidity driven and ICD code driven. And increasingly what we're trying to encourage is that there should be sort of quality control measures, and that somebody has to at least interact with the healthcare system like one time in order for you to, otherwise, like the first time somebody shows up at your ED, they could be wheelchair bound, but it's the first time your system's seen them, then suddenly they look robust. And then what we're worried about in those situations with those tools is then people are just going to ignore it because the person they see in front of them, clearly there's a disconnect there. And what your EHR is saying, oh no, they're robust, when in fact you're looking at somebody who's wheelchair bound, you're just going to start ignoring that information. So we want to make sure that's being measuring things that are meaningful, but also, like, to your point, this person's frail, you're the one that ordered the walker, so you didn't really need it to tell
Right.
you that. I think that the claims-based measures are, to be honest, I think always going to be limited towards research, just because there is the lag time of generating the claims. But what can be really powerful about those actually is we can now go back and reanalyze trials, or kind of do real world data things, where a lot of older adults, being excluded from trials, we know that, like, really frail patients never got lecanemab. That's just a factor, like, of the fact that, like, pharmaceutical companies were not going to recruit those people into trials. But in the real world, we have some frail patients that are going to be getting it. So now, a year or two later, we can actually try to find those patients, say, all right, well, what did the outcomes really look like for that frail person that ended up getting that treatment, and monitor it in that kind of like a meaningful way. I think that EHR is really going to be the way of the future in trying to deliver frailty assessments in a way that's real time, that's relevant to clinical practice. And because of that, it probably won't actually have things like grip strength, but stuff that's part of the standard Medicare, assessments, annual wellness assessments, like your ADLs and IADLs, that's enough. The frailty index that I showed with all those performance measures, you don't have to put the performance measures in. All you need is the comorbidities, the ADLs, the IADLs, and then a couple questions about, are they able to, like, stand up on their own? Can they write? And then that calculates a frailty index. That's the denominator, for most of the FIs that I do, actually. And that's all captured in annual, like, wellness
Right.
assessment.
Definitely. I see actually in the chat. So Lona Modi, good to see you, Lona, from Michigan, is saying it's really eye-opening to see your efforts on recruitment. Can you reflect on time and resources that go into recruitment of older adults from nursing homes for patient-oriented research? And then she's got a follow-up set of questions too.
Yes. So, recruitment. I feel like recruiting patients in nursing homes could be like its own separate talk, much less frail patients. I think that I'm still honestly trying to find that balance. There's nothing to me that beats doing live patient recruitment and again being able to measure what you want to um and getting real kind of patient oriented measures. So I didn't present all the data, but I have, pain data, I have patient reported outcomes, depression, all of those things that aren't readily capturable from things like claims. It is really tough to recruit older adults. I would say by far the biggest barrier for me was the healthcare proxy activation and cognitive impairment, particularly folks that were delirious coming from the hospital or those with, and sometimes we were the ones that were recognizing like this person has mild cognitive impairment, this person has probably moderate dementia. And for the purposes of this pilot study, because we had, believe it or not, I had initially wanted to try to include people as long as I could, have like a legal author, a healthcare proxy or something sign the consent forms. Our IRB was concerned that having like aides or non kind of rehab staff, that you could imagine if one of the exercises was walking, like what if this frail older adult was walking up and down the halls and fell, right? So that safety was actually a concern from their perspective. And they said, no, this is really, since safety is going to be one of those things we're looking for. By the way, no adverse events, like nobody fell. There was no danger to having people do the exercises that PT is asking them to do anyway. But I had to kind of demonstrate that like frail older adults can exercise and they actually want to exercise and there are safe ways for them to exercise with arguably not even, they don't even really need to be supervised. A lot of our participants, if we left the exercise bands there on the weekends, they were like, hey, just leave me a stack of protein bars and exercise bands and I'll do this on my own, on the weekend. We saw that happen over and over again because there's nothing more motivating for an older adult than saying you either get stronger or you're never going home again. And so
Right.
the safety thing, I think, was a concern. I think we were able to demonstrate well that this is a safe intervention, but our hope would actually be that I think the cognitive impairment step is one of the trickier things. Um, and oftentimes it was the clinicians that were saying, I think that this person's too frail, or I don't think that, cognitively they're able to really participate in this research because they don't understand what the research is. So I think that, I guess this is a long way to say, recruiting really challenging, especially if you're going to rely on follow-up calling people, they're just not going to answer. And we asked for 2 or 3 backup contacts to try to get a hold of this person. Still really hard, especially these days. Nobody answers like spam phone calls from, nowhere. I never do. And so that was a huge concern for us. Sending mail questionnaires, I think it's a work in progress in terms of trying to understand how we can really continue to follow these really frail people in the nursing home and once they get to the community. But I think there needs to be an entirely different way of thinking about recruiting and following older adults who are vulnerable with limited social resources and cognitively impaired. Because I can tell you right now, I wasn't able to do it, and none of the traditional study research mechanisms um, that I was able to kind of try were able to capture that population.
And one other comment from Lorenzo, and I apologize if I pronounced it, Lorenzo Pes, about have you considered using AI agents to try to remotely sense the state of the patient in a more longitudinal and fine-grained fashion, perhaps deliver personalized small cognitive therapy style interventions? And I will say there, we visited Pitt and went to their sort of healthy aging home, and they have like loads of sensors all over and things that for the home, which I'm sure are also available in nursing homes. But have you integrated any of that into your research?
So I have not yet. In my limited experience, we tried doing things like active pal or actigraph watches and sensors in, I didn't mention some of the other work I've done. A couple of things happened within so anything that has to get attached to a patient can also come off of that patient. And then that kind of becomes its own can of worms, in terms of like whether it's even not capturing anything anymore. Sometimes like with the watches, they take it off, they give it to the roommate's gone, and then you're like tracking watches that have just disappeared. And then anything that's actually embedded in the environment from a nursing home perspective gets very tricky regulatorily, because then you potentially have like a broach of concern. What if the roommate didn't consent? Then you're capturing passive data about this roommate or all of the staff that are coming in the room. And that feels like a violation of privacy from the staff. So those kind of ambient sensors can become very tricky from like a data privacy perspective. You mentioned, I know that a lot of people much smarter than me are doing amazing work in trying to develop remote sensors for frailty, using wearables or wireless kind of technology, heat sensing technology. I think that all of that stuff is going to be very powerful in the future in terms of safety monitoring. I have not seen anything that has been able to kind of deliver real-time personalized interventions, to say, oh, this person's gait speed is slowing down. It's slower today than it was yesterday. Maybe they need to have like more protein today. I think part of that is also just we don't know that this field is developing so quickly. We don't know, like, is it significant if somebody's walking a little bit slower today than they were yesterday? What should the trigger and the threshold be for delivering another intervention?
I think we're like right up against the hour. So Dr. Bradley, you want to?
Yeah, thank you so much,
Close.
Dr. Shi. This was great. And thank you everyone for joining us today for this wonderful talk. Really appreciate you being here, and we'll hopefully see everyone again next month at our November pepper rounds. But appreciate everyone's time, and thanks again, Dr. Shi.
Thank you so
Thank
much
you.
for having me, everyone.